Hi, everybody. A warm welcome once again to the 29th episode of the 4D program, which tries to reach out to each and every one of you so that all of us can benefit from the great expertise from the fantastic experts who come on this show to help us understand how we can manage diabetes and its complications, its comorbidities much better in our country, which we all know is facing a huge epidemic as far as diabetes is concerned. And today I have the good fortune of interacting with Dr. Emmy Grewal, who is a consultant endocrinologist from Max Hospital, Mohali. Welcome, Emmy. It's such a pleasure being with you. As we all know, Emmy has received a number of awards. She has an absolutely illustrious career, A.V. Gandhi Award, the MMS Ahuja Award, and now the A.V. Seth Award for Best Oral Paper Presentation, and has a number of publications to her credit. And I know we are going to enjoy listening to Emmy over the next half an hour. Over to you, Emmy, to tell us what is your opinion about the scenario in India today.
Thank you, Dr. Shaila. Thank you for the very nice words. So today we'll be talking about why the prevalence of diabetes is increasing in India. We know that India is becoming the diabetes capital of the world. So if we see that almost in India, there are 90 million people who are living with diabetes. So that turns around to 1 in 11 adults, which is a huge number. And the problem in India is that almost 50% of the patients are undiagnosed. So what we are left with is a huge population of diabetes who are diagnosed, who have complication, and almost 50% who are undiagnosed. That means they have this burden of diabetes, and occasionally many of them present with the complications, or they are undergoing any surgery, so they are diagnosed with a diabetes. So that leads to people being untreated for a long time, leading to the diabetic complication. So almost it has been seen that other than diabetes, there are 40 million people who have impaired glucose tolerance or pre-diabetes. And we know that in India, the risk of developing diabetes from pre-diabetes is also pretty high. That is around 2 to 3 years, 50% conversion rate. So we have huge population of people who are with diabetes, and these, why does the diabetes is much more common in India and it's rising? So there are various factors which has been given. So one, it is reduction in the physical activity. We know with urbanization, with long working hour, the physical activity has taken a back hand. Then second is there is increased availability of processed food, not cooking at home, eating out, large amount of fast food, which has large amounts of calories, and particularly the cold drinks, which have large amounts of processed sugars in that. That has been related with the diabetes. And also the population is aging, but it has been seen that in Indian population, the diabetes occurs at an earlier age as compared to the Western population. So as our elderly population is increasing, more and more number of people are diagnosed to be diabetes, and also increased prevalence of obesity. We know that in India there is rising obesity even in the children. Around 30 to 40% of urban kids are obese. So that, and also in adults. So even like in cities like Chandigarh, where 30 to 40% of females have obesity or overweight. So that leads to increased diabetes, and also because of genetic factors, because of Indian population has increased risk of type 2 diabetes. So there is a survey which was conducted in ICMR, which found that in by 2025 there is around going to be 70 million population of Indians to be with diabetes. So what is important in the diabetes, that there is in Indian population, the patients are undiagnosed. Almost 50% are undiagnosed, and if they are undiagnosed, and Even on diagnosis, many of these patients are uncontrolled. So, what are the reasons for that? Because of lack of awareness of diabetes and its complications. Many people don't know of diabetes, and even if they know, because doesn't usually produce any symptoms, so they do not try to get it controlled. So that leads to increased complication. So another problem is that there is lack of accessibility to the diagnostic measures. So there is a huge urban and rural divide. Whereas the population doctors are there more in the urban population, there are very few in the rural areas and also in the remote areas. And also the good diagnostic facilities are not available. So patients are not diagnosed, and once diagnosed, they are not treated well. So again, the economic drive between the urban and rural setting, and there is also scarcity of qualified health personnel in the rural population. And even in the urban, there is a divide between the well-off people and the patients who are poor. So that leads to the social barrier. So as if we talk of the rural and urban divide, there was a report which was released in Lancet in 2017, which said that prevalence in the urban population is almost double. And what is fearful, that it is increasing in the lower socio-economic population. This is because there is increased availability of the cheap food in the recent year, so that these people are also becoming more and more obese, whereas the higher strata they have more of better kind of food, more of fruits, more of salad. The people in the lower socioeconomic status, they are have relatively high amounts of cheap and the food which is more dense in the calories, so that leading to obesity and more of diabetes. So what are the social implications? So that can lead to the increased risk of complication, because these are the strata which have increased the these are the strata which have increased availability less availability of medical facilities. So how about the undiagnosed case? We already said that almost 33% of the patients are not aware that they have diabetes. And also, even if they are aware, they are not treated properly. Only thing the many patients do know that to monitor the fasting blood sugar and also to monitor the post meal blood sugars, but they are not aware of HbA1c levels. So if we see that many studies in which HbA1c level was only done in the 1/3 of the patients, and they were aware of this, of as compared to almost 97% of the patients who were aware of fasting and PP blood sugar. So how to manage the diabetes in Indian patients? We all know that diabetes, it starts with the first and foremost, in as in most of chronic disease, is diet and regular exercise. The patient has to be on disciplined diet, which has to be 3 meals a day, with a good amount of with good and equal proportions of the required components like carbohydrates, proteins and fats. And also the patients, everybody as such, patients, not only patients, they should have regular 30 to 40 minutes of exercise daily, above and over the the daily activity. So then after that, the patient has been explained about the diet and exercise. Patient need to have regular medications. As we said that there is lack of awareness of treatment. Many patients do not get treated because they don't have any symptoms. So very important is that we have to tell them about the diabetic education, that this diabetes is a chronic disease and is later on going to lead to complication. Higher is the blood sugar, more is the likelihood of complication. So the patient should be made aware of these. And if they are going to do their blood sugars, then only they are going to get treated. So repeated blood sugar monitoring, and the patients have to be regular with their medication. So, and the diabetes, we don't just treat the diabetes, because it is in a comprehensive care. So, in order to decrease the complications like cardiovascular complications, the risk of which is 2 to 3 times more in the diabetic, we need to control their cholesterol level, need to control their blood pressure, and also ask the patient to stop smoking if they are. And also, we have to look for the diabetic complication by monitoring their renal function test. We have to do the ECG, yearly eye examination. So it is just the complete comprehensive diabetic care, not just the blood sugar monitoring. It has to be monitoring of sugar, blood pressure, cholesterol, taking care of the complications like renal complication, eye complication. And in case the patient is obese, losing 5 to 10% of the weight is going to help them in controlling the diabetes. And also other things like good oral hygiene. So what are the treatment strategies for diabetic patients? So what is very important is that there should be early initiation of combination therapy. It initially, few years back, it used to be start with a lifestyle modification, wait for 3 months, add a single drug like metformin, wait for 3 months, and then keep adding the medications. But we now know that diabetes is a particularly aggressive disease, and if not managed well early in time, it can lead to poor glycemic control that will lead to the more and more complications. So it is always see according to the HbA1c level, start with the drugs. For example, if the HbA1c level is around 6.5 to 7.5, maybe a single drug or a combination of two drugs, which can be later on decreased. But if it is more than 7.5, the patient will usually need more than two drugs. Because what has been seen in the Indian population is that there is high amount of postprandial hyperglycemia. So the metformin only is not going to help. And also, other than diet and exercise, the patient can have drugs like various drugs like DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 analogs. The benefit of these drugs are that few of them, like DPP-4 inhibitors, are weight neutral, whereas the SGLT2 inhibitors and GLP-1 analogs also cause weight reduction. So, adding these drugs in combination along with the metformin helps in controlling the blood glucose. And the other advantage is that the diabetes is, no, as we know, there is multiple causes for it. It is because of insulin resistance, uh, decreased insulin production, and multiple factors. So adding multiple drugs helps in controlling the multiple pathophysiologies. So it should not be just wait and watch, because many times the patients are told that your HbA1c is 7.5, you can just start with a one drug, that is going to be enough. So we need to add drugs at appropriate time and control the blood glucose at the earliest rather than waiting and watching. So what is this new combination of SGLT2 inhibitors and DPP4 inhibitors for tight control of glucose? We know that both these drugs act at different levels. For example, the SGLT2 inhibitors, they cause renal glucose excretion, which helps in blood glucose control, decreasing blood pressure, and also helps in decreasing weight. And because of these factors, it helps in improving the insulin sensitivity. So they act at one pathway, that is in diabetic, we know that these patients have impaired glucose excretion. So they act at this pathway, decrease the glucotoxicity, and also help in reducing the weight. And also they have been shown to improve the renal as well as cardiac output. Whereas the drugs like DPP4 inhibitors, which helps in one, it increase the increase the gastric decrease the gastric emptying, decrease appetite, and also cause insulin secretion, which is glucose dependent, and also decrease the glucagon level. So this also acts at various pathways, and if used along with the metformin, so they act at almost most of the pathways, decrease in appetite, that also increases the glucose excretion. So the combination of these two drugs along with the metformin is acting at various pathways of improving insulin release, decreasing insulin resistance. So that leads to prevention improvement in HbA1c of almost 1.5%. So this is a combination of SGLT2 and DPP4 is a suitable option for type 2 diabetes because it helps in causing the rapid sustained glycemic control, improves insulin resistance and beta cell function, helps reduce body weight and blood pressure and reducing the pill burden. So this is overall cost effective. Yeah, thank you.
Thanks a million, Emmy. That was really
Yeah,
fantastic, and it really gave me an insight into the not only the situation in India at this point of time, what we often talk about the urban-rural divide, why we are not where we ought to be, and what we can potentially use so that we actually get to where we should be. It was fantastic listening to you as always. And I'm going to quickly ask you a few questions, Emmy, to try to
yeah.
understand that why do you really think, Emmy, that India is the diabetes capital of the world? We have so much of undernutrition. We have, at this point of time, I think we are seeing both ends of the spectrum, a huge amount of undernutrition and a huge amount of overnutrition, maybe the westernization of our culture, maybe the bad lifestyle that we are increasingly adopting. But why do you think, what is it that makes us the diabetes capital of the world, Amy?
Yeah, very rightly, as you said, Dr. Shelja, you have already elaborated that we have actually too much of divide in the nutrition. On one end, there is undernutrition, and another hand, there is overnutrition. So the both these spectrums are actually increasing the diabetes. We know that undernutrition also there is a factor like genetic factors like thrifty hypothesis, which was implicated that Indians have been undernourished for a long time. So that lead to the some genetic as well as environmental alteration, so that there is excessive fat storage. So we know that the child who is born very under the below weight SGA babies, they have too much of insulin resistance, and once they grow up, there is increased insulin resistance, and that leads to increased incidence of diabetes. So these both ends, undernutrition as well as overnutrition, it's going to leading to the increased prevalence of diabetes in India. So even if we see the compare the data of Western population versus in Indian population, recently there was a study in which they found that in the countries like US, the Indians who are just slightly overweight, their risk of diabetes is as high as the very obese European population. So somehow our genetic makeup has changed, that it is predisposing. Even in overweight category, we have very high risk of diabetes.
So that means, Emmy, what a very important message you're trying to give is that it is actually transgenerational, and
Yeah,
maybe it is, the mother's health plays a very, very important role in also in the entire story which is, unfolding at present in our country. So I think
yeah,
it is something that we need to keep in mind. So I mean, what we should always hear as kids: look after the mother. Mother's health is very important. I
yeah.
think all those factors actually now come into play when we look at our pay with this increasing epidemic of diabetes. Totally agree with you on that, Emmy. Emmy, what I wanted to understand from you, is there any difference in the way we treat our patients and the Western population treats their patients? In the sense that, it's become such a small world with so much of Dr. Google, with so much of, information very, very easily available. And of course, all drugs which are now available to us at a very, very reasonable rate, I would say. But the fact remains that our patients pay from their pocket. Of course, that's a very, very big difference. But do you think there's a difference in the way our population, we treat our population and the way the Western population is treated?
Yeah, the factors, see, if we see that divide actually starts from the patient itself. You know. In the Western population, the most of the times the medication, they have insurance and all, they are more aware. Our population, the awareness is lacking. So many of them don't know about the diabetes, though now this awareness of diabetes is quite high. People do get their routine blood test and also, but even after the diagnosis, unless and until they have some problem, they don't get treated. They feel that if they start on medication, that medication is going to go lifelong. And the most often thing you say is here is that, oh, metformin caused kidney problem.
Yeah.
So they always ask, is these medication going to cause any kidney and eye problem? So that problem starts from there only. So the education of the people is a one major problem. And the second problem, as you said, that once they go to the physician, so there is, as we already saw that study, the HbA1c is very underutilized tool.
Yes.
So there are so many fallacies in HbA1c, but still it is now widely available, but still it is not utilized. Most of the time, only value we see is the random blood glucose. And the patients come up from far off place and they want you to get to treat them according to that sugars only.
Very true.
Other problem is, yeah, we have to think about the money and all problem, because now the guidelines have shifted that if the patient has any underlying cardiovascular disease, use SGLT2 inhibitors more often than GLP1 analogs more often. But that is hardly the case, because of the some of the drugs which are much more cheaper, like sulfonyl ureas, are much more commonly used. So the many of the medications are underused, the diagnostic is underused. For example, even for the evaluation of retina, simple retinal evaluation is not done in most of the patient unless they have decreased vision. This is many time on the part of physician, but mostly on the part of the patient. They refuse to get it done because since they have very good vision. So
Totally, I totally agree with you. I mean, I'm totally, on the same page on that. And I think another area where we really do not diagnose our patients or on time underdiagnose them is as far as diabetic nephropathy is also concerned. We simply, as you said, you see she patient is being followed up for years, but has still does not have a single EGFR report in those papers. And that is something which is, really something which we should be maybe educating, maybe emphasizing more, because as you rightly said, we now have drugs which can actually change the pathophysiology of the entire disease process. And when you have drugs which can make a real big difference to the progression of complications and comorbidities, yes, we think we need a change in our thought process also as to which direction we go in and how do we manage our patients much better. Amy, do you think it is not only clinician, it is also physician inertia to some extent? I mean, patient inertia you just spoke about. Do you think that there is some amount of physician inertia? We hesitate to sort of investigate our patients on time. We hesitate to really look at the ABC of diabetes control. I mean, is it a little bit of problems at both ends?
yeah, it is actually the problem at both ends. We have patients who are not educated, and we have physicians who don't want to educate the patient. So once a person goes with a diabetes, A is taken, HbA1c is not done, BP is not monitored, cholesterol is not seen. So as I said many times, if the HbA1c is 7, the first thing patients tell me is that no, he has been told don't to start the medication, just try with the diet and exercise for some time. And once the patient has been told such thing, these are the things they actually like to hear, so they very faithfully follow that. And then for years, unless they have some complication, they don't do it. So it is so we need to disseminate knowledge not only to the patients but also to the doctors, that these things have to be yearly monitored. So many times what happens that people do think, like even physicians do think, that this is going to add to the cost of the therapy. But we have to think of long term cost, because these diagnostics are not very costly. These are
Agreed.
very easily
They're
available.
reasonably priced at this point of time. They're
Yeah.
definitely reasonably priced at this point of time. Totally agree with you. Amy, there was one more. I mean, this leads to me to another question, which often crosses my mind. I mean, how do you really think? What would be a effective way to actually reach out to people and educate them? What could we do? What are we not doing right? Why is it that I mean, sometimes I look around or when I read around, I mean, patients come to me with these information from quacks, from all kinds of sources saying, "Okay, ma'am, this is what is being said." Where is it that how can we actually reach out to people?
Yeah, I think the people actually hear more what they want to hear, so that the quacks are taking advantage of it. है ना? Like blood sugar, high blood sugar does not cause anything unless you are not symptomatic. So I think we have to disseminate more knowledge through the Facebook, through the media and all, because the people who give the knowledge as the patient wants are usually more effective. So we have to make little more effort to disseminate, maybe through the Facebook, as we are doing so many activities, and
Very
also in
true.
the maybe in the groups, like as individual doctors we can various corporates and in the senior citizens and all. So even usually in the people who are well educated, usually that problem is not there, but in the strata which is economically poor, we know that diabetes is now increasing in the people who are from the weaker socio-economic status. In those, there is actually quite a the information is lacking, and also in the rural population. So we need to maybe keep telling, even in the clinics we have to tell the patient and the relatives also to get tested. So ask them
I
to bring their reports also, rather than, and just how we can change the environment and surrounding in the family. It's not just the diabetic patient who has to change their diet, it has to be the whole family. So we can start from the small steps like that.
I totally agree with you. I think when we are educating our patient, it's often, a family member, maybe a spouse or a child, or sometimes even a grandchild who would actually be more resistant to what you are saying than the patient. Especially, we
Yeah,
often see this at the time when you want to initiate insulin. When you're talking about insulin initiation, you often, I mean, sometimes you're a patient because the patient may be suffering and may be more willing to listen to what you are
yeah,
saying, but the relatives is like, no, 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 ma'am, no insulin, don't talk about
yeah.
insulin. Do you think we use insulin adequately in our country, Emmy, or do you think that, yes, we use, we don't use? What are your viewpoints about insulin?
Yeah, there is a biggest inertia in any medication is to the insulin. That is I think more from the physician side also. Then once the physician is willing, the patient does not want to take. Actually, if we see our population, the patients do come once they have been to so many doctors. So usually patient is compliant, and we tell also. But many times what happens, a primary care physician, he will think that if they advise insulin, patient is never going to come back. So there is a lot of inertia on the part of the physician as well, and also it is a very time consuming process. Then other factors like weight gain, hypoglycemia, both in the patient's mind and in the doctor mind. So all these, as we said, it is just again educate, educate, and educate.
Yes, I think that's a very important message Emmy is giving everybody out there, that we need to educate our patients, we need to educate our patients' families, and I think we also need to, empower them so that they are able to better take care of their diabetes, because
Yeah,
education does lead to empowerment, where they would be actually be more involved in their own diabetes care, and that really transcends economy, that transcends age. I've realized, I mean, some of my elderly patients will be more compliant, more enthusiastic about what they are doing than, a very young patient. So we learn as we go along that, without any mental barriers, we need to explain and educate everybody. Totally, I mean, I think that's a very, very important message that Emmy is giving to all of us today. And I will come to the last question of the day, Emmy, in the interest of time. At this point of time, Emmy, we have been very fortunate that, to a significant extent, we could manage our patients in the pandemic because of telemedicine. We all, I mean, had a great learning curve as far as telemedicine was concerned during that phase. At this point of time, also, we continue to use telemedicine. Do you think that it could help us reach out to that huge rural population out there, which really, potentially could benefit from better care, or we could reach out to more people, or maybe clinicians via telemedicine? How do you think we should now, where should we strategize telemedicine now, Amy?
yeah. So the telemedicine, if we see like in our setup, one is the people who are from very far off places. You know, we do see people coming from the rural backgrounds who are not very often able to come. So that is one of the biggest barrier to start medication, and especially insulin. So in those cases, it is going to be very helpful. The first visit can be in the clinic, and later on patients can keep following with the telemedication. So that is one scenario. Though in the rural background, people are not very comfortable with the telemedications. So from our cities, it is not that comfortable as in maybe Mumbai and all. And second, as you rightly said, it can be like it can be organized along with the physicians in the periphery who are in the rural area. So they can organize that telemedication. That is going to, because most of the patients can't come to the cities and get treated. It increased to the cost, their days are lost, and that.
Yes, totally agree. It's a very cost. It does save a lot of cost. I totally agree with you. But as you
Yes,
said, patients often are not completely satisfied. Also,
that is
they
right.
somehow that maybe the human touch is missing, or that
Missing.
conversation across the table is missing. But a lot of patients, even in Mumbai, do not feel completely satisfied with telemedicine. So I completely agree with you, but I think in certain situations it can be tailored to individual needs, and where patients do need it, where distance is a problem, where patients do require somebody to sort of, maybe they need somebody to help them out further, that would be the best way forward. I think, Emmy, that's been fantastic. Half an hour just flew by while talking to you. And
Thank
I really want to say a big thank you to you for being with us tonight. It was great learning from you. And I hope all the listeners have benefited as much as me. Thanks
thank
a
you.
million.
Thank you. Thank you, Dr. Shala.